Everybody. This is Sarah DeSilvi, the Director of Terminology for the Gravity Project. We have a very packed agenda today on our first call of September. So we're going to get right into it. Welcome, everybody. Next slide, please. Thank you for joining. As always, if this is your first call or you're 2 years in to all of us, we always mute everybody on entry because of the sheer number of folks who arrived at the call. Like right now, there's about 35, but usually we end up with about 100 to 150 folks. The call is, we ask that you remain muted just to avoid background noise. The call is always recorded, and every recording is available on the Gravity Confluence page after the meeting. As you all know, I do try to work the chat. So if you write anything in the chat, I will do my best to include that in the conversation in a timely fashion. And then there are regular pauses for conversation and when everybody can unmute their mic. We do ask, is anyone else not hearing audio? Can you all hear me?
We can hear you. Yep.
Okay, thank you. So Tom, folks can hear me. Okay, so I just wrote him because obviously he couldn't hear my reply. All right, thank you. So please send chats to everybody just so we can make sure that everyone is seeing the conversation from an inclusion perspective. And I do always say this, if you send a chat directly to me, you are at risk of having me read it out loud because I have a hard time discerning who the different senders are. So if it was something specific or private you wanted me to just know, send it in an email after the fact. Next slide, please. This is our standard antitrust practices slide. Next slide, please. Okay, so participating in the Gravity Project, of course, this call is the anchor and heart of our work. We invite everybody on the call to participate in the project by joining it officially. By joining, you become part of our quorum for votes for our consensus voting process. If you already sign up, you get all of our emails, which there are a lot. You can always check whether or not you or your organization have already signed up. And then again, the Confluence is just a cacophony of information. We really are trying to figure out how to organize it better. It's like an ongoing process, constrained really by the way the way Confluence pages work, but we're doing our best, and we're hoping to have some effort on that from all of our partners over the course of the next weeks within our education dissemination initiative. Next slide, please. This is just a list of our project founders, grantors, and in-kind support. If you are offering in-kind support and it's not currently represented on the slide, please let us know. We do ask all of our subject matter experts whether or not their organization is supporting them or whether we are giving them honoraria. So all of our subject matter experts, if the org has been supporting their work, you'll see that here too. If you have, I think the next slide has information regarding funding. So next slide, please. If you are interested in having your organization become a sponsor, we're more than honored and happy to talk to you about that. You can just write the general Gravity Project at emiadvisors.net email, or we have information on the Confluence regarding how to become a sponsor and who our sponsors are. Next slide, please. Okay, there's a lot of Sarah. And then there's Mark with an update from the policy side, and then Bob with the technology update. What we'll be covering is the announcements. Really nothing's changed in the project schedule and overview. There are some things in the announcement section though. We're going to update on some concepts. You know, we need to start getting concepts in front of folks' faces. You're going to see some concepts that are in the hopper regarding social connection, elder abuse, and our demographics regarding the goals and interventions concepts. And then we'll go through policy and tech, and then we will adjourn with our homework. Next slide, please. Announcements, next slide. So each of these elements corresponds to an announcements page on the Confluence. We always do try to elevate the Fire IG public meetings on Wednesdays from 3 to 4. Our amazing partners in San Diego have the Community Information Exchange Summit coming next week, and both Mark and Evelyn and I are all presenting. We're very, very grateful for that collaboration. I think this is the second year running that we've talked about gravity and our work there. Our colleagues at Sync Health have an annual conference on the 20th and 21st. We talked about this last meeting, but the Congressional SDOH caucus, the comments on that are due by September 21st. And you can get more information on all of these announcements on the Confluence page, which is just the Gravity Project announcements page. Next slide, please. I am going to highlight here and also talk about next steps. So this, as we've mentioned in past calls, is the easiest way to find the existent code in each of our different domains. There's an updated spreadsheet on the that last column, the links to codes to date spreadsheet. We created this for our implementers. We are meeting to try to figure out how to make this more user-friendly. It's very difficult to differentiate the work that we do on the public call initially, which is the identifying what we want to say, with the code that's actually been built. So look to have this possibly be improved. But again, if anyone's looking for the code that exists now, both code we're building and code that was already in the ecosystem before Gravity's work arrived, this is where you can find that. Next slide, please. All right, and this is going to take a couple minutes. So we just had enough final information that we can start talking about the upcoming ICD-10 CM Coordination and Maintenance Committee meeting on September 14th and 15th. I'm going to spend a few minutes on what's going in front of the community, and this really is hot off the press. So forthcoming, likely in the Tuesday email, this meeting, or even, next week or even the week after, and on the Confluence, we'll give you information about how to participate and give you access to the final submission. So first of all, just a process point, the way ICD-10 CM submission works is you submit a submission quite ahead of time of the September 14th meeting. So we submitted it in June.
Enter your attendee ID.
Oh, there's some background, so if somebody can mute, that'd be great. And then we also submitted, the code going in front of the community has really been, the CDC ICD-10 Coordination Maintenance Committee has really been in process since December of last year. So we do not have a lot of control over the submission once the committee and the experts on the committee have done their work. So we submitted our concepts, they refined the submission, and then they will present it at the meeting on September 14th and 15th. So I'll mention this again later, but I'm going to mention it now. The best way for Gravity and the community to participate is to make public comment the same way we would if it was not our submission. So just letting you all know that. So thanks, Ellen. And again, so the SDOH elements going in front of the committee on September 14th and 15th are a combination of Gravity submissions, a submission from the American Academy of Pediatrics, and a submission from another organization that we don't know the name of. So they're all in one submission and will all be presented by the staff within NCHS at the September 14th and possibly 15th meeting. We don't know which one yet. The Gravity elements, many of them have not changed. I do want to highlight, I see Charles is on the call. Charles, expect very shortly a kind of an urgent meeting with you and the VA team in order to make sure that this is okay from the VA perspective. But so the Gravity elements that were unchanged with our submission are all the ones that are not in bold. So transportation insecurity, financial insecurity, material hardship, patient non-compliance with dietary regimen, secondary financial hardship, and then patients' non-compliance with other medical treatment, which really was when you can't afford not just medications or dietary regimens, but other elements of care due to financial hardship. And those were all part of our December submission. There's been a significant change, again, which was not in Gravity's control, but was done by the committee. We submitted a code for personal history of military service to represent veteran status, and there was already a personal history of military deployment code. So the committee, instead of creating 2 codes, is putting forward a request for just this one combination code. There might be a lot of thoughts regarding that. We anticipate there being some thoughts, and we're going to reach out very quickly and swiftly to our friends at the VA. And again, this is Charles, that's why I called you out. So in this instance, it may not be in, again, I don't want to discuss it too much right now. I guess, Charles, I'll let you have your comments, but it may not be that we actually recommend this code once we talk with our subject matter experts. Yes, Charles?
No, I don't want to take from your time, but exactly, I'm here to help when the time comes. That's what I have been waiting for a long time.
I know you have. I know. You're so great. We're very grateful. We just need to make sure, because Gravity has a process that really leans on subject matter experts. So whenever there is a change in something that we have suggested with subject matter expertise, we're very clear to the committee that we have to go back and make sure that it still represents the intent. So, right. Charles, thank you. You're great. Can't wait.
Of course. One thing is just one quick, brief comment. As you mentioned, the personal history of military service is kind of very comprehensive and may mislead, right, the representation of the service member. More to discuss offline, but thank you.
Yeah, I hear you, and we definitely want to elevate the VA's wisdom in that. So this is the only change in the first set from Gravity, and then I want to go to the next slide, please.
Sarah?
Yes, hi.
Hi. I'm wondering if you could go back to the previous slide.
Yes, we can.
Does Gravity submit elements, and this committee then assigns Z codes, or do you and the subject matter experts recommend the Z codes to accompany the elements that you would like to be coded?
Well, we do actually recommend them, because part of our job with any taxonomy is to integrate it into the logic of the taxonomy. So there might be slight changes in the actual code after it goes through the work of NCHS, but we try to do our due diligence. And this is why we work with, Linda Hyde on the terminology team is just an expert in this. And then we work very closely with our friends at AHEMA. And we also worked very, very closely with our friends at AHA on the submission to make sure it was as tidy as possible before it came into the hands of NCHS.
I see. Thank you. Is it possible that the Coordination and Maintenance Committee could accept the elements but change the numbers? Does that happen? I guess I'm wondering, what is the relative importance of Gravity's submission here? Is it elements that now need attention, or is it also the number, or is the number just your best judgment about what the number should be?
The number as it stands
code,
right now, the code, the Z91.190 or Z59.87, that would be the code if the concept was approved, because it changed very little from Gravity's submission. So we worked it into the structure of the taxonomy. It came back to us as the NCHS's formal presentation, right, that they will present on the 14th and 15th, and it would not change if it was disseminated, which would be a year from now, October 2022. I hope that's helpful. Yeah. So usually there's very few changes from this point out. And Tom, it's an and or based on the way ICD-10-CM works, which is different than SNOMED CT. So it's even larger, which again, with referencing Charles's concerns, might mean that Gravity in this instance actually says just go back to what it was, and we'll keep on trying. But we lean to our experts in the VA on that one. Okay, and we will have a further conversation and come back to the group. And I anticipate pretty rapid fire communication with the community through our many different pathways. Confluence, email, etc.
Sarah, one more thing. It's not only the VA, it's the VA for the veterans and DoD for active service member. Just want to make sure both organizations are going to be represented. Over.
That sounds wonderful. Yeah, sorry. I'm sorry for being a layperson speaking incompletely.
No worries, but I just went for the benefit of the audience.
Thank you so much.
And Sarah, for those of us not familiar with the military, personal history of military, whatever, this refers to the actual person in the military, not to family members.
As it stands, yes. It's the person, not the family.
Is it ever of interest to
Well, the family could be actually. I again, I'm not the expert here, but and if Charles or somebody else has a comment, and again, I really want to be careful not to spend too much time when we go and come back. Yeah.
So, quick thing, yes, family member as well. So there are 3 groups need to be represented here: veterans, which is a separate department and separate group; active service member and their family. Absolutely, DoD look at the family and the service member as a part of the readiness. So they are absolutely essential part. We had the chance to talk about this during the Connect-a-thon, CMS Connect-a-thon, and we explained it. I presented the DoD views, and since I'm from the Defense Health Agency at the firm, I represented that. We had folks from VA represented the veterans. I would direct you to look at the CMS Confluence page. I can put the website on the chat, but I don't want to take more time during this conversation. But thanks, Sarah, for allowing me to explain it. Thanks.
Oh, Charles, my lord, I defer. Yeah, I mean, like, thank you so much for being here and all your wisdom always.
Because I've read that multiple deployments can have significant impact, for example, on mental health of family members. So that's what I was trying to get at.
Yeah,
so
that's why I
thank you very much.
Charles talking. Maurice, do you have something you would like to say?
Yeah. Do we have SMEs working on elements in parallel for civilian mass casualty exposure and deployment, or civilian extreme event, vis-a-vis, a month and a half on the pile at Southside, or 2 years at the pile at 9/11, the current events going on with Ida, or prior events with Katrina.
So that hasn't been identified. Correct. Yeah. So this work came specifically out of our focus on veterans within a domain. We have a very so we have a very specific a specific in process for domain selection, but I think that that's a very interesting thing, and I look forward to figuring out how gravity, interesting and necessary, she says, from a family medicine perspective. So we look forward to figuring out how we could address that collectively in our future work.
I'm disaster medicine, so
there we go.
Happy to help you find or assist on that when that becomes an element that we're ready to address.
Wonderful, thank you so much.
I also have a background in air engineering, so that's why I started with SDOHs, from a different set of qualities, but I'm very thrilled to be working with you guys.
We're honored to have your expertise. It's the many hands make labor light approach. So we have a couple more questions in the chat here. Again, I do want to thank Daniel for his comment regarding the experience. And again, I'm the daughter of a person in the armed services, so I definitely can speak to that personally as well. And VA would like to help with this codification as well. So John, please just write, in this instance, write me. So we will ensure many hands on deck. What happens if you just write the Gravity Project at emiadvisors.net email? That's actually the best way, but you can CC me. My email is available on the Confluence and at the end of the call, and I will put it into the chat as well. We have to kind of make swift work on this, and then because of the edit, and so getting in consensus before the meeting in September is a fairly urgent and pressing matter. Even though the public comment, is available long after the September 14th and 15th meeting. That's my email. Dangerous to email only me. Always CC gravityproject@myadvisors.net because of all the different places that I am at once. And John, thank you for leaning in and offering to help. We did work with individuals from the VA specifically in the original proposal in December, and we'll reach back out to them as well. Okay, any other questions on this page? Okay, it is really important to understand, like, we literally just got this morning, so we really are glad to spend some time on this. I do want to make sure that we look at the next page as well. Again, because this is an all social determinant submission combining a few different organizations' work. Next slide, please. All right, so the next one would probably be of interest. I mean, I'm family medicine pediatric faculty in the med school, so the American Academy of Pediatrics has a really timely and necessary extension of some of the non-compliance codes, really covering when the non-compliance is the caregiver and not the patient. So they are submitting these 3 codes. You can see we did not expand all the different codes in the taxonomy that are related to it. So this is just a representation. You can see the plus other means that there's other codes underneath it as well. And so they have non-compliance with dietary regimen, secondary financial hardship, intentional underdosing of medication regimen due to financial hardship, and unintentional, right? So that is specifically the AAP submitting those. And then another one, we don't know who submitted this. There is a health insurance insecurity concept, which has evolved really rapidly in its title over the course of the last couple of weeks. We have a fair number of thoughts regarding this one. Really, I'm going to go to the next slide, please. Oh, so someone has a question. Is there a consolidated computer readable file of gravity codes that we can use in a database project? We're working on that right now. We do have the supplemental guide available on the Confluence, and we have those codes, the spreadsheets I mentioned. I do want to state, which I forgot to mention on the, I'll go back to this slide in a second, but I do want to state, and I forgot to mention on the table, I really want to do a special session just on how to utilize existing deliverables. That wouldn't be a public call. We really can't get to the subtleties of all that and just answer any questions ahead of people wanting to pilot and implement. So computer readable file coming, looking for a special session just regarding how to apply and access existing code in the near future.
Sarah, can I inject a quick comment?
Yes, you can.
Yes, Linnell James. Just a reminder for when we talk about computer readable files, some of these codes that are used have licensing requirements. So for connectathons, we've been given approval by entities to use some set of codes in pilots for connectathons, but outside of a connectathon in production, some code sets have to have licensing, so you can't get a human readable form from us if it's got licensing external to HL7. Just a heads up on intellectual property reality for computer work. Thanks.
Thank you, Linnell. And then Monique, our amazing colleague from the AMA, was kind enough to do a link to the supplemental guide on the Confluence. So thank you. Oh, thank you, Charles. That's you're such an amazing community member. Okay, so I'm going to go back just to some really important things before we close up the ICD-10 and move on to all the amazing other things we have to cover today. So we've already reached out, because there are a few different elements of concern, we've already started reaching out to our subject matter experts to assist, because we really want to go into those meetings and our public comment with their wisdom in hand. We do want to stress again, nothing that you've seen can be edited. What was presented to us is how we'll go forward into the community as presented by the committee. And then we will have the ability to to make public comment after the fact. We do just want to say some things that we already noticed. Financial insecurity and health insurance insecurity have the same inclusion terms right now of medical cost burden, and that's not the way the logic usually runs, so that has to be sorted out in public comment. We don't understand the current definition of health insurance insecurity, and it has some inclusion terms that really seem to belong in other places, so we'll try to work that out once we get the formal official submission back to us. We do just want to stress what I mentioned earlier, that Z91.82 is that combination, and it may not be appropriate. So we go out to the Department of Defense and our VA friends to ensure that we get that correct. And then there are some concerns with the inclusion terms, which are really like the normal language under all the dietary compliance elements. So there's a bunch of things that we have to sort out and comment on. We haven't even gotten the official comment submission back from the committee yet, and it definitely hasn't been posted publicly. So as soon as we're able to, we will post the final submission and give suggested text for commentary on the Confluence and via email. So just know that we just got it, we just processed it, and we will get back to you as soon as we can. Again, this is very, very short turnaround. The meeting is the 14th and 15th, but the comment period afterwards is really where a lot of the work happens. Any other questions before we move on? Oh, here we go.
Sarah,
Yes?
Sarah, I just want to thank you and all the team for realizing that our interminable discussions about concepts and elements actually have to reduce to codes in EHRs. I certainly wasn't clear about that at the beginning of this project, but all of our work does need to be condensed into codes. So this whole conversation is not just interesting, but really signifies how this project has been organized and whether it wants to be influential, and clearly it does.
We're trying. I want to just make a comment on what's happening in the chat. Like, part of what's going on is the question regarding the differences in code sets. I really do want to have a special session on that. It's very clear that our members of the community really want to get implementing and working with the code sets, but I don't know if we have the time or the nuance to answer those questions in the chat like well. And I feel like we do need to like focus on the work that's happening on the presentation. So I've in my mind, I imagined a special session just on this that we can leverage and make sure that everyone's questions are answered well. And so just know that we recognize that that's a requirement and necessity, kind of like, you know, now that we're getting into implementation and piloting, and we want to offer that to the community. And just know that you can, again, we'll try to answer any questions we can in the chat right now, but it might be that that special session is where those questions are best answered. Any other questions regarding ICD-10 CM? Okay, and so Bob, are you saying the link that was posted by Monique is inaccessible?
No, Sarah, that link is the one that Greg put in.
The link posted by Greg is not accessible.
Okay, so
it fails.
Okay, so what we'll do again, we do plan on that special session, and we can hopefully have tech and terminology folks there just to answer the questions of the implementers. I'm going to try to keep on going, only because we have a lot to cover. Next slide, please. All right, next slide. There are no edits to this page, so if it's okay, I'm just going to quickly highlight it. We're right here. The timeline is wrong on this one. Sorry. It was right on Tuesday. We're working on, it's the beginning of September, working on social connection, elder abuse, unemployment, education, and veterans. Ahead before the end of the fall, we will be addressing stress and intimate partner violence. Our work on all of these is to finish our goals and interventions work with some focus on some subdomains that weren't addressed in our work in the spring. All along, we are planning for future connect-a-thons. We're jumpstarting our work on the pilots. And Bob will talk to more about the tech part of it in very, very, very shortly.
Sarah, where's racism? At least a year ago, maybe more,
correct.
We were told that we would address racism. So where is that in the schedule?
So it's not here because I'm going to be clear. So when we have been talking about addressing racism, discrimination, and bias, the way we are having to approach it is through things that are person level and measurable. So the elements of racism, discrimination, and bias we have on our timeline in January, And we even have talked about it with the USCDI, you know, as things we're committed to for this session of work. If you think about like a school year, are minority stress and elements of discrimination. And there's lots of concrete screening tools that can lead us to concrete terms in those areas. So elements of discrimination measures and minority stress measures are absolutely part of our future intention in the beginning of 2022.
Thank you.
They have not disappeared, and we have all the screening tools lined up. We have our work cut out for us. We have the intention of collaborating with our colleagues, of course, in the Office of Minority Health and Health Equity, and we will humbly approach that work in 2022.
Sarah, can you start sharing just a composite of the parking lot issues? I think that might help. Is that something you can put in the slide deck?
Yeah, so we certainly will. So we do, I mentioned this in the last meeting, I think, but we're finalizing a domain selection process with the executive committee, and that will really help give us a really comprehensive roadmap for what is available. And then there will be an area on the Confluence, which is already incredibly busy, I know, that will show things that are on the roadmap, things that are in process, and things that have been submitted but not processed yet. Right, so we do this work I mentioned regarding assessing measurability and associations with health risks. If anybody wants to formally propose a domain, you are all welcome to just send an email, say, I propose this domain, and then it becomes part of the process. I hope that's helpful. We have another draft of the proposal going to the EC next week. And then it should be a lot clearer, because the parking lot, Lilia, is very large right now.
The parking lot is full.
I know. Yeah, it's quite large. Okay. Any other questions? And I just, Lilia, because you mentioned it, and I know your work with AHIMA, of specific interest to members of the EC is health literacy. So given that we had to kind of push forward food deserts and neighborhood safety, we might start addressing health literacy really quickly. But again, that depends on what comes out of the EC meeting next week. All right, next slide, please. All right, any questions? Okay, next slide. All right, terminology. I know I'm not done. Here I go. I'm going to keep on talking. Good thing it's only 4:33. Okay, this is the just the terminology, but some of the roadmap. Next slide. Here we are. It's September 2nd. Again, we're working on goals and interventions concepts for social connection, elder abuse, and the demographic elements. You'll see how that work is playing out very shortly. Next slide, please. All right. Okay, so just some engagement guides. So the intent of the public call is to present updates of gravity materials. Whenever someone has, once we start doing end-to-end review, whenever somebody has any comments that might offer a change, we do ask for rationales and evidence. There, believe it or not, is a rationale and evidence for every single thing we do on our side. So whenever we offer commentary, we want to make sure that there's some, and we query folks for evidence. So if somebody were to submit a comment, we query for evidence back, and our lovely members of our intervention council can testify to that. Next slide, please. Would we also just want to state that it can be challenging. We acknowledge to kind of enter midstream if you're kind of new to our work, but all of the different domains we've addressed in the past are on the Confluence. So if somebody has a question about a domain we have not covered yet or covered in the past, we try to bring that offline through email just so we can keep on going, because our agendas are quite large, as you are witnessing. Next, and we do want to state very clearly that we gather our subject matter experts by domain. So like right now, we are working with subject matter experts across all the domains we're addressing. So if there's a question that deals with a previous domain or a future domain, we might just need to put your answer on hold. Next slide, please. Okay, Next slide. Any questions? I don't think that was pretty straightforward. This is us. I'm going to breathe through this. I'm the amazing team I have the honor to work with. Next slide. All right, next slide. We're now going to go through some putting concepts. Oh yes, so the meeting's always recorded and available on the Confluence after the call. Jenny is saying, I think it'd be useful to depict on the roadmap parking lot what SDH concepts will be included in the upcoming Connectathons. Maybe Bob can speak to that when he's presenting on tech. And then Carrie's saying she seconds that. So what you should be able to see in future testing, and I don't want to preempt, is there is a lot more content to play with in the sandbox now than there was in the past, as you can see from the supplemental guide. I'm sure Bob will speak to the SDOH concepts when he speaks. And I'm just going to go back to the slide here. At this phase of the terminology development, the terms really represent concepts that are in process. And so the goal is meaning. We really want to get the meaning across, that semantic consistency. Wording comes next. Like you might see wording change from meeting to meeting as we kind of refine things with our subject matter experts. You even might see wording change when it comes out of terminology build with the terminology standards organizations. Like sometimes that happens with SNOMED CT. As long as it references the meaning and intent of the concept, we just kind of knead the dough of the concept as we keep on going on. Next slide, please. Next slide. We said that because there's a lot of things in process. So it's, again, our goal is to develop the goals and interventions concepts for all the screening and diagnoses only domains we addressed in the winter and spring. They were, as a reminder, less than high school education, veteran status, unemployed, psychological stress, which is differentiated from other elements of stress. And you heard me, Lucy mentioned minority stress, which is a facet of stress as well. A social connection, which includes social isolation, loneliness, and lack of social support, intimate partner violence, and elder abuse. It's big. Next slide, please. The core of the interventions, again, are the programs and professions critical to addressing the social risk at hand. We always, as you've heard me mention before, align with federal reporting requirements and policy requirements just to make sure we're working in sync. And we anticipate mapping to community taxonomies, such as 211 LA, and we've talked about that extensively in the past. And friends, in fact, we have our 211 LA colleagues review much of our content to make sure it's not dissonant. And then we work the professions and programs into the intervention structure. Next slide, please. This is the structure that we wrap around. They're all common definitions. So again, whatever program we plop in, the meaning of the term, like a coordination of or provision of, is maintained and then just coupled with the code. We imagine in future times this being able to allow post-coordination, right? So if we have a program taxonomy, we can keep these concepts in sync in their definitions and then sort of plug in the program code only. That's kind of future state. Next slide, please. All right, goals. We have a common way that we're doing goals. We really have we're leading humbly, leading the field in trying to figure out how to represent goal terminology as we collaborate with our friends across many different elements of work, including the NIH eCare Plan initiative. So we really are working first on terms to represent the desired state when one has a social need. So, and then we also do these plateau domains that mark progress that we build to. For example, food insecurity is the problem, food security is the meta goal, and then you have these sub goals that are part of the domain. If you remember our definition, number and quality are elements of the definition of food security. And then in homelessness and stably housed, you can see stably housed is the meta goal. And then, but individuals who are homeless aiming towards being stably housed might not, one, be something they desire, or two, be something that's feasible to have as a goal. So homeless and sleeping safely is a plateau goal, like a goal that will mark progress, maybe not the meta goal, but something to arrive at. So this is the kind of the way we've built goals in the past, and you'll see that in all of our terminology suggestions as we go forward. Next slide, please. These are our amazing social connection subject matter experts. Just so grateful. They come across the community in social isolation and leading researchers in social isolation in the national, international ecosystem. Next slide, please. And we're now going to this is the work in progress, right? So again, it's one of the things that I think is most interesting about this work is this goals approach, right? Is trying to represent terminology for goals, because as someone who does care planning with my patients in rural Vermont, it's almost always just a free text thing that comes out of their mouth. This is what I'm aiming for, right? We do imagine goals being able to be utilized both as patient-reported and provider-reported goals. So we build as minimally as we feel like is necessary, and imagine implementation and piloting really helping us figure out whether these are practical. But this is our first stab, as we've done in the past. And I do want to state again, these terms can both be provider goals or patient goals, or they can be asset statements as well. So when we're doing like eco mapping or complex care planning, you don't just want to focus on individuals' risks or deficits, you also want to name their assets. So this goal could also serve as an asset statement. So for instance, I might have transportation insecurity, but I am participating socially because I carpool with my cousin, right? So there's all kinds of ways you can imagine that playing out in real time. And you can tell I work in rural Vermont. That was a rural Vermont story. So, so for the goals development, social connection is the meta domain that kind of covers all of its different subdomains. So a goal statement might be adequate social connection. The term adequacy related to goal statements is something we've utilized across all of our goal build. And for those of you who are part of the work with food insecurity way back in the Wayback Machine, you can remember how we settled on that. Social isolation, the goal statement might be participating socially. Lack of social support is adequate social support. Really, the use of adequacy, it represents the fact that these concepts exist on a continuum, right? So what is adequate to the person might not be adequate to somebody else, and perfect might be too far afield. So the statement of adequacy really being a place in the continuum that's sufficient for the person. Loneliness, right now we have not lonely, understanding that not is a little complicated, so we're still working through that. But this is kind of what we're playing with within goal statements. Again, if you have any thoughts or comments, please submit them via email. If you want to state things right now, that's fine too, but it's difficult to pull things from the chat. And we really want to make sure all comments are logged formally. We have a change log. All of our processes are very visible. So if we want to go back and understand how decisions were made, we can track them. Any thoughts about this so far?
Sarah, do the subject matter experts use the term social connection instead of connections, plural? Could you explain connection versus connections?
I think they do use the term social connection versus social connections. I think it's, I'm trying to figure out, because social connections are very concrete. If my social connections are something, are this, that, and the other thing, and again, if anyone who's a SME from social isolation is on the call, please pipe in. But social connection is the name of the meta domain, right? So all of like social isolation, lack of social support, and loneliness and poor relationship quality are all subdomains of social connection. We did define them, Lucy, early on in our social isolation work and social connection work in the spring. I can pull those back for you if you like. You would suggest that social is plural. I don't know what that.
Well, I don't know, as a layperson, connections plural to me is slightly more more of a layperson's understanding of what's going on here. Whereas, it's like we used to
I'll bring
say
that back.
we used to say pants with an S, and the fashion industry decided that that wasn't sufficiently faddish. So now we read about pant. So
I will bring that back to this means, and I don't know if it matters so much, but I will suggest that as an idea. I don't know if they're not attached and we feel like it's better with plural. I think that's fine if you mean in the goal statement, but certainly in the domain statement, social connection, that is the name for the meta domain, the same way food security is the name for the meta domain over there. So, but if we want to consider adding an S to adequate social connections, I can bring that to this. Bill's like, SNOMED won't allow plurals. Thank you, Bill.
Oh,
And Sarah, I was gonna add there that very often, and it may be that the SMEs use the word connections, but very often these high-level terms go to the singular because the singular can also encompass the plural, but they don't use the plurals at these, in these grouping type terms. That may be what's going on here. It may not be, but to the point about SNOMED, that's true in many of these sort of taxonomies. They leave the singular, even though it can mean singular or plural.
And I have to
Thank
state
you.
the only reference I have is as a philosophy undergrad, where concepts are usually singular, right, versus plural. But again, Lucy, every comment is valid, and I will take that to the SMEs.
No, that's okay. I just obviously touched on something that I've never really thought about before, and thankfully people have been thinking about this for terminology purposes in the health sector, obviously, for a long time. And if it's convention that the singular is understood to encompass the plural, that's a very interesting idea to me, and I appreciate hearing it.
Thank you. And all of these are subdefined on the current master. So if you're looking for the definitions for the terms themselves and the literature supporting that, the master we voted on in the spring has all those, right? So if you're looking for the specifics there, and if somebody has a different goal, please submit it formally. So we want to make sure it comes in via email, and we can bring it up to the SMEs in the normal way. I like Tom, I love that idea, but we want to make sure it comes through the normal hopper. And I'm sorry to be, because I just don't want to lose things in the chat, right? So if you have an idea, drop an email, send it to gravityproject@myadvisors.net, and we'll make sure we process it accordingly. Does that sound like a good plan? Okay. I love we're having like philosophical conversations as well, of course. Next slide, please. I just wanted to state a quick work on intervention. So no specific intervention concepts right now. However, we actually have some for two different reasons. So we're working with the Committee to End Social Isolation and Loneliness on their interventions initiative that they already had going with the Administration of Community Living. So they were doing a kind of a national initiative to glean programs for social isolation with ACL in collaboration with 211. So we are parsing some of the terms and concepts they have from that work for our submission for Gravity. So you'll see that come very, very shortly. There's a lot of specific program types in that have to be sorted into meta types that aren't specific, right? So there's names of programs, but not the kind of program type we would have to have within Gravity in line with our work in submission. So that's what we're doing right now. We also can state very clearly that we are including any Older Adults American Act food security programs that address social isolation. A really good example of this is home delivered meals. One of its primary intentions is as a safety check and social isolation initiative, like intervention. So it's food plus people. So those interventions will drop onto our intervention spreadsheet as well. Okay, is the goal different? I think that, so Matt, that's an element of diagnosis and person preference. So we imagine all these terms being applied to the unique person. He's asking about the goal, whether the goal is different for somebody who has isolation and loneliness as well as social anxiety. We did kind of play out some of these use cases when we think about our goal statements. If you have any other ideas, you're welcome to submit them. But we do necessarily imagine these things being said by people, right? So, and with part of what we think about the plateau goals, like a goal for somebody with social anxiety might be very different than a goal for somebody else. So if you have any specific ideas, please let us know. All right, I think, did I miss anything? I'm trying to make sure I, okay, thank you, Serafina. All right. So, and again, if you have any program submissions, please just drop them. And Lolita, we have been working off the amazing submissions you've given us in the past. So please just, again, anything that's proprietary or regional, we have to parse into a national program type. So we basically do research to try to figure out what type of program it is so we can build that term, because we can't build a proprietary program. Okay, next slide. I'm going to try to quickly, it's a good thing we're going to use our hour and a half here. These are the elder abuse SMEs. We're honored to have Dr. Jeffrey Hall join us. He is the Deputy Director of Office of Minority Health and Health Equity and the Chief of Minority Health and Health Equity Activity at the CDC, and an expert in violence. So he's swung into our meeting last Friday and just offered incredible insights, of course, instantaneously, about the intersection of violence and social determinants of health. And it was very beneficial. Next slide, please. Again, and one of the things that's been interesting regarding this work, and you'll see this with social isolation as well, is in this realm, our SMEs are research SMEs, they're content SMEs, but they are also connecting us with further intervention experts on their multidisciplinary teams in order to ensure the program and interventions types are set. So the social workers, the care managers, all of our folks on the intervention council will understand this. It's really what we're seeing is in this work, the folks who are best able to help us with the program and intervention submissions are really the boots on the ground, not surprising. So we have lots of connections within the social workers and care managers on these multidisciplinary teams. We do anticipate also having to work with our intimate partner violence colleagues to ensure that any program types are built in sync, as some types of elder abuse also are intimate partner violence, and we want to make sure that we build in kind. So right now, that's where we are with elder abuse. Next slide, please. We want to show our goals. This is something that really is a work in progress. This is probably the most challenging area we've done goals development. What you can see here is that the broad domain that kind of encompasses elder abuse and other types of abuse is interpersonal violence. So again, in the aim of trying to understand what a person might say, the only goal statement that exists right now in SNOMED CT that seemed appropriate was the goal of feeling safe, right? But that's not a goal that applies just to elder abuse. It's really all of interpersonal violence. So we put this up there on the top as kind of the final goal. Within elder abuse, what we're working on with our subject matter experts are those plateau goals and those final goals, right? Again, all of these have to be parsed within the rules of the taxonomies. You know, all SNOMED CT, we anticipate the complexities of building with our terminology organizations, but what we're working on is the sense of adequacy and resolution, right? So what we know about working again with elder abuse and intimate partner violence is sometimes things aren't over, they're just better, right? Especially within elder abuse within long-term partnerships and intimate partner violence within long-term partnerships. So what we have right now as a plateau goal is the concept of adequacy, and we're playing around with that. And then final goal would be resolution. We don't have terms yet for elder neglect and financial exploitation because safety is doesn't really apply there yet. So we're kind of working on that. We meet every Friday morning to try to figure out this stuff. This is, I'm going to say, quite hard work. There's a lot of going back and forth trying to figure it out, and there's a lot of testing about how these terms are going to be used, and a lot of this is hypothetical, right? So gravity in this space, as I mentioned earlier, is building for the intent of these different programs that we partner with, and knowing the requirement of building goal statements for care planning and outcomes measurement. But again, we'll figure out whether these work in test, but we just kind of want to give it a good solid try. Anything else from on this table, which is honestly humbly a work in progress, which we'll see how it goes. Carrie,
Sarah,
I thank you for, yeah?
Sarah, does adequate safety imply legal interventions when needed, like separating people being abused from those who are abusing them? Certainly for children, separating them is a long-standing custom, law. So what does this actually mean?
Well, remember, this is something a person would say, right? So I think whenever we're talking about elder abuse or children or vulnerable adults, which we're also working on now, you almost always have to report to APS depending on the age of the individual, right? So adult
Mhm.
protective services is involved, or child protective services is involved whenever you really have concerns for safety. Because I'm a mandatory reporter, right? Um, so in this instance, you can imagine it being applied in different ways depending on whether the patient's saying it or whether the provider is saying it. Again, we're trying to build for each of those different uses, and we really are hypothesizing how it would play out in real life. But I can tell a story about a patient saying this and me saying this and it meaning different things for us, which is a little bit complicated because that kind of defeats the semantic consistency bit. But in all of our goals work, we do also, so far, our IG allows for free text as well. So you could imagine this being kind of the lighthouse term and then explanatory free text being beneath it. But again, we'll have to figure out how this works. We're doing this because this is a first step and we'll see what happens. Does that make sense? Okay.
I don't know. I mean, I'm just one person among 80 people listening to you, and I'm imagining reporting that I feel that I'm being abused, either physically or psychologically, and perish forbid sexually. And then you're the provider. What are you going to do to reach this goal? And if what you do, I'm trying to understand whether what you do in response is encompassed within the term adequate safety. So is there a discussion somewhere what this means?
Yeah, so we actually have these discussions every Friday at 10, right? So this is the elder abuse. We all sit around.
I mean written. I mean notes, practice notes about.
Yeah, so that's what I'm going to say. I
Okay.
was going to say next, right? So like we have the diagnosis statement, right? Elder physical abuse, right? The goal statement in other domains, such as food security, you can really imagine it being part of care planning. That's the way we were always imagining it, right? But you also, and this actually came up, the reason why I referenced those, and again, I'm sorry we're taking so long, but this is important stuff, right? So we have an hour and a half for this meeting for this reason. So the elder abuse SMEs really wanted to go directly to action. They're like, okay, so if this is what I am aiming for, I could have a drop down and I could say, I need to do these things to achieve this end, right? And that's all very possible. We can imagine that being part of maybe a build or, clinical decision support. But I think that's all, like right now, I know it's what I said in this meeting on Friday, every meeting on Friday morning, we have to build for these efficiently because we don't want to create terms that aren't useful. We have to build efficiently with things that seem useful across multiple different use cases. And then implementation will teach us kind of what you're looking at, like what happens next and the how. Again, because that's all I can do as a terminology person is just try to allow for these multiple different uses when we start getting into piloting and testing. Is that helpful?
Thank you.
Okay, and it's tricky because we don't want to build a bunch of stuff that's fluffy and no one uses, right? We want things actually to be employed. All right, okay, I'm going to try to get through really quickly and then pass the mic. I can't see what Mike Klinkman's referencing, so I'm having a hard, but we'll go forward. Next slide, please. I think that's it. We just wanted to, demographics really quick. Again, we already mentioned the DOD. I'm sorry, I didn't put it there. Noted. This is our amazing interventions council. Again, I'm sorry I didn't put any of your titles on here or your licensures. They're not in the spreadsheet, but I acknowledge that you're all experts in your field. And I'm sorry, I didn't have any referencing regarding licensures and training. So this is the amazing group that we meet with every other Friday at lunch. Next slide, please. Again, goals really for demographics are quite simple. They're the opposite of the problem. I couldn't imagine one for veterans, and maybe Charles and VA folk, we can figure whether that's even remotely possible. Really, it's just high school education is the high school diploma or the GED, and then unemployment would be to be employed. They seem very concrete, and these terms already exist in SNOMED CT. Next slide, please.
Sarah, what about the gig economy? If you go back to that previous slide, that the
Okay.
opposite of unemployment is employed. For a lot of people, the opposite of unemployment is becoming a gig worker where they're not employed. So can you address that?
So if there is a term that, do you mean consistently employed versus seasonal employment versus, because the moment someone,
I mean that there's a huge debate now, for example, in California about what it means to be earning money.
yeah,
Some people think it means being a gig worker and you're earning and you should be happy. Other people think it means that you have a job, whether it's full-time or part-time. At least there are defined parameters about what you're supposed to do and what you're going to get paid and whether you have benefits and so forth. So I'm just, I guess, having a very contemporary reaction to the term employed as the opposite of unemployed. It's
okay. So
become much more complicated.
you want to give space for the different types, because for you, employment means something more. We follow the,
I mean, you can be earning money. You can be earning a good living by posting videos on what is it? Oh,
many different ways. Yes.
yes. So the fact that you're unemployed doesn't mean that you don't have revenue, that you don't have income, and even that you don't have capital.
So I think wage earning, what you're trying to do is differentiate is between earning money and employment. And what we'll do is we'll take, these are all federal terms that we try to align with, really from this is one of those census elements. So let me go back and see if that subtlety can be expressed. And it certainly could be expressed in probably better than we have it right now. Lovely. And then somebody had something regarding, that's something we'll bring to our friends at the VA and the DoD. Noted. That's actually really interesting. Okay, next slide, please.
Sarah, if you don't mind.
Yeah.
One group of active, I would say, the National Guard, they are like similar to the veterans, that they have a full-time civilian job, and sometimes they don't have a full-time job, and sometimes they get gap in health insurance, and so those groups should also, we definitely want to address them as we progress in the profile of service member. And I just want to give this as an example of similar kind of a semi-veterans kind of a status.
Yeah, so one of the things we talk about in our interventions council is special populations. And then we also talk about what it means to be a person, what it means to carry one risk, and then in the process also have secondary risks, right? You can imagine having an individual who's in the National Guard who is also otherwise unemployed, right? So so I think that's one of the things we try to figure out is like how to pull out the other drivers of social risks in order to intervene on them. And yeah.
One of the things, but again, that's going to take it offline. But the good news, we have a breakdown of the occupational, military occupation, and National Guard is addressed there. So that's maybe a starting point. Over.
Yeah, and I think Monique has been very kind and shared those with me so far. Wonderful. Adequately employed is interesting. I think that seems, but I think we have to figure out the employed bit too, because employed implies a relationship. I think what Lucy was trying to pull it, yeah, with an employer. So I want to honor the fact that Lucy's speaking to something where it actually might be like financially secure is the goal or something to that effect. But I don't know, Lucy, if unemployed would be the problem then in the same way, but we'll have to figure that out. So Lucy, that's in the hopper. I promise to try to figure that out as well.
Thank you. Employee, being employed means you're an employee with an employer. And that's, to me, a very 20th century way of looking at being able to earn a living. And there's a gigantic history and sociology about employment based on those touch points, being an employee and having an employer. And in the 21st century, we're discovering that a lot of people don't want to do that. A lot of people can't do that, but a lot of people are figuring out how to earn in order to live in a capitalist society without being an employee. So thank you for bringing this up with the subject matter people. And I'm getting the sense that there are really important refinements with respect to military and National Guard. So this isn't one of those self-evident things about whether you have a high school diploma or not.
Yes, and one thing I do want to state is someone mentioned this as well. For all of our domains, we imagine a goal of just maintaining, right? Like if you don't want to change, you don't want to change. I know we've had a conversation about that in the past, but we've been very adamant in all of our work that that is something a person could say was their goal, right? Maybe it doesn't apply in this case, but Linda, you had mentioned that. I just want to give space to that. And thank you for all the references in the chat. And this is just the word clouds, they haven't changed. Yes?
The one thing I will add with the unemployment issues is that on your site and in the discussions you've had on this, you haven't defined unemployment as regarding an employer. You've said it's the state of being jobless, looking for a job and available for work. So people who are self-employed aren't considered unemployed by your existing definition. Or people who employ themselves doing something on the internet where they make money or something else. I think your definition handles a lot of these issues.
Correct, yeah. And we just want to make sure that our goals do as well. And I think we can just make sure that we can take this out, have some thoughtful conversation and come back. Again, you guys always provoke very good thoughts. Again, I think that this is the end of Sarah presenting and an hour long. And then there's a lot of conversation regarding honorable discharge. I'm going to leave that to my colleague. Oh, wait a minute. I'm not quite. I'm going to leave that to my colleagues. I'm going to bring that to the experts, the VA and the DoD that we already have in the call. And we can capture the chat and make sure all of your questions come directly to there. The only thing I wanted to highlight with the Interventions Council, and we talked about this earlier in the call, is we are really trying to figure out what special population consideration lenses we want to apply to whatever program build we have to ensure that from a policy perspective and from a tracking perspective, we're thorough. And so part of our work is not just identifying programs and professions. We've had lots of really lovely conversations and we'll continue to have them on just lenses of populations for programs, whether it be ESL, incarceration, differently abled immigrants, refugees, foster youth, LTSS, indigeneity, SOGI, race, etc. Because just as we did, my example that I offer here is in past build, we only had food pantry. And then when we dropped the lens of Native American indigeneity onto the food pantry, our colleagues in that community were very adamant that federal distribution, food distribution program for Indian reservations was a critical program they needed to have represented. So we also built that. So as we're doing programs and professions, we're also really trying to make sure from a special population perspective, from a social justice perspective, from an access perspective, we include any programs that's necessary for special populations as we go forward. My Lord. Okay, Sarah just talked for an hour. If anyone wants to moonlight into the Interventions Council meetings that we have every other Friday, just send an email to gravityproject@emiadvisors.net. And I now pass the mic to Mark. Oh my gosh. Next slide. Okay.
Thanks, Sarah. Next slide, please. So in the at the last meeting, I mentioned that the U.S. CDI, U.S. Core Data for Interoperability Task Force at the Office of the National Coordinator had asked the Gravity Project to present on our work and plans for the U.S. CDI version 3 and any recommendations that Gravity might make to the task force as they tried to make, to help the Office of the National Coordinator to think through process. They were very engaged, as I mentioned, and they asked us for some recommendations. I didn't present on what those recommendations were last time. I thought I'd take a couple of minutes this time and just share what they were, and some of the good effect that they appear to be having. So next slide, please. So the first was a more particular recommendation about considering data elements like food insecurity or data elements like assessments, not to just consider them alone, but to consider them as part of a larger whole, to consider the multiplier effect, because these individual data elements are building blocks for larger purposes and larger use cases. And we specifically lifted up some that are not yet in the U.S. core data for interoperability, but would make a tremendous difference if they were. Functional status, cognitive status, pregnancy status, health insurance information. On the right, you see the current draft, at least the draft as I looked at it yesterday, and this is the draft that the task force will present to the Health IT Advisory Committee next week, and indeed they include those 4 data elements. So Gravity Project's thinking is making its way in this draft. Here's one example. Next slide. Second recommendation from us was the task force consider the need for multi-directional electronic information exchange, that it's not just sort of a one-way referral from a clinical provider. There's all kinds of multi-directional exchange that's needed in order to have better care coordination. And we noted as examples that the patients and family caregivers and community-based service providers might be the primary source of data, and that they may be the ones initiating assessments. So definitely would want them to be able to be presenting the data as well. And on the right, you will see that the task force, at least in the current draft, is looking at a slightly larger structural way of phrasing that recommendation. So should application programming interfaces, the kinds of things that are in electronic health records and indeed smartphones and the internet, should they allow for writing information coming into the electronic health record, not just to send it out? So this would be the kind of capability that would enable multi-directional information exchange from patients, family caregivers, community service providers. Also, a more particular draft recommendation about supporting the use of FHIR questionnaires to help with patient-generated health data, social determinants of health, and data utilized in research. Next slide, please. Third of 4.
Does multi-directionality address security and confidentiality?
It is. It's silent about that. It assumes, since those laws are apply, it assumes that all of that will be taken care of, but it does not subsume within it all that requires. It just says make sure that you can write information in some way. It doesn't even specify how. There are multiple strategies for doing that. But the patient privacy, patient security would be another layer that should exist, and does exist now, even though there is no write access. It exists with what are called read access application programming interfaces. Does that answer your question?
Yes, I hope that won't be lost sight of, because multi-directionality, I mean, we have unidirectional, I'm most familiar with bidirectional, and now we're talking about multi-directional. And at every step with respect to communicating to relevant parties, security and confidentiality has to be kept in mind, wrapped around, dealt with somehow. Thank you.
Okay. And I think in bidirectional and multidirectional are pretty much flavors of the same thing, if that's reassuring to you. On this recommendation, consider how new data elements in version 3 might advance other core use cases beyond clinical care, which has tended to be the focus. And we gave as examples COVID-19, clearly been front and center of much of our considerations, population health, public health, digital quality measurement, and so forth. On the right, the draft recommendation includes a significant list of core national use cases that the task force is recommending that ONC keep front and center as it is assessing whether to add a data element or not. So this is really helpful. It sort of makes concrete the kinds of things that ONC should be thinking about as national priorities in considering data elements. And indeed, I think ONC is, but it's good to have a metric against which to evaluate things. And lastly, to the next slide, please. The fourth recommendation was to consider how elements might support person-centered and advanced care planning with patients, providers, and care team members. Just the kind of thing that will be happening around social determinants of health, and we pointed out the significant benefit. And indeed, this is repeating the previous draft recommendation, but just focusing on all of the pieces that would support person-centered care, advanced care planning, so patient access, value-based care delivery, shared care planning, remote care, patient-generated health data. So another example of where Gravity is contributing both to immediate next steps like US CDI version 2, but also helping to contribute the community's best thinking to the longer term arc of evolving the digital health ecosystem. Thanks very much. I think I pass it off to, are there any questions, if there's time for them? And Bob, I think I pass it off to you.
Thank you, Mark. So we'll go through fairly quickly, given the amount of time we have left, where we are on the technology side. Next slide, please. This is where we are on the roadmap. We are getting ready for a Connect-a-thon in September. We have completed and published the standard for trial use 1 version of the implementation guide. It is available on HL7. We're working with the reference implementation to incorporate things that we're considering for the next version of the guide so we can test them in Connect-a-thon. The plan at the moment is to ballot the second version in January and to add things that are really focused on primarily connections to the individual, the patient, the client, and the ability to connect to community-based organizations that have applications but are not FHIR enabled. So those are things we're working on at the Connect-a-thon right now. Next slide, please. The current scope of the guide, and by the way, we'll talk about what's being tested at the Connect-a-thon, is to support assessments or surveys and exchange that information to be able to go and define health concerns and problems as SNOMED, CT, and ICD-10 coded and exchange that information. The ability to establish goals. Sarah went through a number of things that they're doing on the terminology side, but to have them coded as both LOINC and SNOMED CT. And then to talk about interventions or referrals and what was done. So not just the fact you referred somebody, what actually happened as interventions and procedures, basically as service requests if you're doing it on FHIR, and procedures to document what was completed. And in that case, we are using the code systems for SNOMED CT, CPT, HCPCS, and we have the ability to support part of that with LOINC. We're looking at how we would participate along with NCQA in reporting quality measures. Sarah's involved directly with that, and I've been involved through the work with Da Vinci on data exchange for quality measures, which is sponsored by not just HL7, but also by NCQA and CMS. So we'll be working on that. Consent, we do have one consent resource that we're exchanging for a particular purpose. We'll show that in a second. And then we are aggregating data, basically creating cohorts of individuals that can be reported for various purposes. The one we use as an example in the implementation guide are all of those individuals that share a common pair. Next slide, please. This is the work that we've done around survey instruments. And I think it's relatively appropriate now. We can take basically any survey instrument that has been LOINC coded and convert it into a FHIR questionnaire, deliver the questionnaire, and record the results of that questionnaire execution as what's called the questionnaire response or observations, which are basically the question and the associated answer. And we have the ability to generate what we're calling health concerns, which are unvalidated at that point, with the idea that they could be validated by the interaction between, for example, the provider and the patient. Next slide, please. These are the various interactions that we have been designing for in the implementation guide, all the blue lines. We have providers on here, payers, government entities. We have coordination platforms, as well as the community-based organizations and the patient and or legal representative and their caregiver. All the blue lines are covered by the implementation guide right now. We're working on the orange lines as part of the Connectathon testing we're doing in September, and the intent is to incorporate those into the implementation guide version 2. So if you're looking at what we're testing right now at the Connectathon, it's on the Connectathon track page, which is how we do Connectathons. We set up tracks and we indicate what we're actually testing. In our case, we're testing referrals, we're testing the survey instrument process, we are testing the ability to go and connect with the patient, and we're testing the ability to connect with a community-based organization that does not have FHIR enablement, but rather is using an application. So that's all part of what we're doing at the Connectathon in basically another 2 weeks. Next slide, please. As we said, we've defined one way to exchange a consent resource. We're only doing one right now, and that is when a covered entity exchanges information with a business associate with the intent of their releasing it to a non-covered entity. We're defining the exchange of a consent resource. That doesn't mean the consent isn't part of the process of exchanging information right to begin with, or part of the collection of information. But in this case, we're exchanging a FHIR consent resource to show that indeed the patient has consented to have that business associate release the information. Next slide, please. This is just one of the screens from the reference implementation. We do have a reference implementation that is open source code available to anyone that has been built by HealthLX to allow us to go and demonstrate the various exchanges that are covered by the implementation guide, along with potential user interfaces to show how you might interact with that information, either in creating it or in displaying it when you receive it or interacting with it. So this is the basis on which we do our Connectathons. We use the reference implementation to connect to evaluate and validate the implementation guide. We also use it to go and show individuals or organizations how they might implement technology to support the implementation guide. And we use it as a testing platform so that we can test against the reference implementation for individuals that have, or organizations that have developed software and wish to go and have something to test against that is a reliable implementation of the guide itself. Next slide, please. We participated in the CMS Connectathon. I think we mentioned this before. We had roughly 40 individuals that participated. This was July 20th through the 22nd. We primarily tested referrals and the support for surveys at that point. The next Connectathon, as we indicated, is September. It's September 13th through the 15th. The sign up is now closed. But if you have already signed up, you can go to the Connectathon site, the Connectathon participation sign-up site that we have on Confluence, and indicate what role you wish to play, and we'll work with you on making that available and tested in advance of the Connectathon. And then we have the track information and a link to it here that shows exactly the detail of what we're doing at the Connectathon. Next slide, please. And I believe that covers this portion of the presentation. Any questions?
Hey, Bob, this is Linnell. One of the questions in the chat was about where HIEs. I believe HIEs are in a part of the IG that talks about multiple hops. Didn't know if that was something you could address or pull up. I was trying to find it, but couldn't get to the link quick enough.
Well, we are testing HIEs. If you'll go back a couple of slides, please, to the almost spaghetti drawing showing all of the various connections. One more. While we don't show it on here, we're treating HIEs as coordination platforms. They have the same fundamental capabilities, the ability to go and create referrals, the ability to go and have surveys administered, the ability to go and exchange information between, for example, organizations on the left, payers, providers, and community-based organizations. So from the way we treat them as far as exchanges, they are coordination platforms. We probably should expand the this particular workflow diagram to show exactly how that would work with an HIE as part of this. Other questions? Or did that answer the question?
Am I correct, Bob, that that's also shown in a strong diagram for the closed loop referral? Includes the strategy of multiple receivers of the data?
Well, the workflow diagrams we have in the implementation guide show how the closed loop referral works, and that's basically by using something called a FHIR task that is exchanged to keep status, and then ultimately whoever's performing the various interventions document what they've done by using FHIR procedures. So we have the way to go and track a particular referral or intervention from the time it is requested until it's completed, and showing exactly who participated and what they did. And that would be true whether it's a coordination platform in the middle, goes directly to a community-based organization that's performing the activity, or going through an HIE to a community-based organization. That would always follow the workflows that we have in the implementation guide now.
And hopefully, Dan, that answers your question, and we'll look at the diagram to make that more clear. Thanks.
Can we
Thanks,
share a
Bob.
link to the nationally validated directory group meeting you mentioned? Yeah, that meeting is on Thursday mornings. It's in the and I'll grab a link to it, and well, assuming we'll have time, and put it in the chat. And if not, we'll make sure it's part of the notes from this call. Okay, I think now I'm handing it back to Sarah.
Oh my word. Okay, next slide, please. What an intense and full conversation we've had. The homework mostly is to submit concepts. So I do want to apologize if we seem like we were racing through. There's so much content today in the terminology side with the ICD-10 submission, and really the first time the community's had a chance to reflect and respond to some of the goals and interventions elements coming out of the terminology work. We do present these concepts again and again and again over the course of the next weeks. The reason why we hope folks can formally submit concepts is that really allows us to ensure that everyone's ideas from here are complete. I mean, one of the interesting things as a group is, when we first started, we used to have, my word, like 20 or so submissions from the community regarding terms. So we've had a shift now where almost all the terms are coming from our subject matter experts and the work of the core team. But if we don't have an email with the idea you have, again, I think of Tom, that goal idea you had, and some of the other things that are mentioned in the chat, it's hard for us to ensure that we represent your wisdom there. So if there's any specific idea you have regarding a goal or an intervention concept, or something we talked about today that you want to reflect on more, just send an email. Or you can formally submit concepts regarding the submission process. We do have a capacity to download a spreadsheet and submit things more formally. Whichever way works for you. Any of the kind of meta concepts, like, really thoughts more than specific concepts or terms, those we bring right back to the subject matter experts, right? So, like for instance, Lucy's comments regarding the applicability of the goals terms, those will fold right back into our conversation tomorrow at 10. And then we meet with our social isolation, social connection folk on Thursdays. So the question of the plurality of the term, all those elements will be brought back to the subject matter experts and then come back to the group. You'll see more terms blooming in front of you over the course of the next meetings. Again, just send an email, submit a term if you want to, and we look forward to making sure that our work is robust. Next slide, please. Not on here actually because it was too late, is just staying attuned to the work of the ICD-10 Coordination and Maintenance Committee meeting. There's some pretty swift work. You can expect, again, that submission to be available on the Confluence, and we'll notify you via email. Specifically, again, reaching out to DoD and VA folks to ensure that the edits that the committee made to our submission are correct, or whether we want to reassess and reapproach. In general, thanks as always to the collective, and we will see you in 2 weeks. Reach out to us if you have any thoughts or concerns, and we are just incredibly, incredibly grateful for you all joining us on a Thursday afternoon, and have a lovely long weekend for those of you that are enjoying the holiday. Thank you so much.
Thank you.
Thank you. Bye.